as Managing Director of PPRE, Community Interest Company, which is a not-for-profit research company, which has arranged today's event with the Council of Mosques. Hanif Osmani, who I'm delighted helped us with this. Well, helped us is an understatement. He and Geeta, between them, have organised this event, which has taken a long time in the organising. But the European project has at its heart the use of informal and ad hoc interpreters across Europe. And by informal and ad hoc interpreters, we're talking about friends, neighbours, colleagues, relatives, who are used as interpreters in the widest sense, particularly in healthcare settings, but also in social care settings. In other parts of Europe, that's often in the absence of paid interpreters, advocates, link workers, etc. But in the UK, it is, and in East London in particular, it's in the context of an extensive system of paid mediators. But despite that, we've done various bits of work, specifically with the Turkish, Somali and Bangaldeshi communities, just looking at how extensive the use of informal and ad hoc interpreters is. And it is still very extensive. And so we've looked at some of the reasons why people might prefer to use informal and ad hoc interpreters, even when there are paid mediators available. The first is that I think it's quite important to distinguish the different things that might be barriers for people accessing health and healthcare. And addressing an audience which I think is mostly clinicians and managers and planners, it's worth saying that although the individual acts of service providers and service patients are important, understanding the context in which they work seems to us central. And the notion that policy wonks use to describe that is cultural capability or capability more generally. If we turn to Tower Hamlets particularly, there certainly is a language issue. We've recently done some estimates for yet another project about the percentage of Tower Hamlets people who speak another language as well as English, or potentially as well as English. And we reckon that about 40% of the population have a language additional to English, of which the largest by a long way is people who speak a Bangladeshi language or dialect, Bengali or Sylheti in particular, and then there are a range of other languages that are spoken.
This presentation seeks to explain by confusing, if that makes any sense. I think probably what I will try to say here is that there isn't a straightforward answer to some of the problems that we'll face and that yourselves you might face in your respective professions. That's not necessarily a problem, and that sometimes just acknowledging that there isn't a straightforward answer and realizing that can actually is a significant step towards being able to treat people's problems and understand them better. So, firstly, some of the basics. There are, in Islam, or when considering Muslims in the Muslim community, there are things that are often regurgitated, things that we hear. It might be through the media, or it might be just every time you sit with a Muslim and you ask them about Islam, these are some of the things they repeat. So I'm going to start off by going through those. And then we have, things that won't necessarily, in a quick 5-minute conversation, come up. And it's often those things that have an interplay, with our various professions, particularly with the medical profession. And then we'll talk about how all of this translates into everyday life. This is how Islam is usually introduced. Islam is this religion, and it has 5 pillars. And these are the 5 pillars. So one of them, of course, is testimony, just admitting that one is a Muslim. Secondly, there are the 5 times prayer, which has other associated things with health implications, which I'll come to in another slide. Fasting in Ramadan, and of course this has a huge impact in the month of Ramadan, There's lots and lots of questions about how fast impacts on health and how, to what extent people are prepared to compromise their fasting for the sake of their health, and so on, and how that affects people like yourselves.
I think it is, in many senses, a unique initiative, and really we need far more of these kind of initiatives. But what I've got planned is that there are no slides. What I hope I can do is hopefully pick up on some of the themes that have already been covered and work with you on some of the issues that you are facing on a day-to-day basis. But I want to go round. Tell me a bit about yourselves and what is it that you would like to get out of the next hour or so that we've got together. Let's start over here.
My name's Caroline. I'm a GP. I'm a consultant in public health. I work in A&E. I want to know when I'm about to advise something that is haram, that they're not going to do what I'm going to suggest. I want to know. Sometimes it's really clear that there's the thing about the fate that's come up. It's like I'm not going to do that. I'm just going to wait for Allah to kill me. For some of the really ill patients. But I also, since I work in A&E and I'm a consultant in public health, I have this really big positive opportunity on health promotion for these groups that come in, don't see other GPs, and I try and do health promotion with them, but I'm not sure that I always do it in the best possible way.
Yeah, okay, so fate, predestination kind of issues and health promotion. I think with that, I'd be inclined to go and tell them to stand in the middle of the road and come back if they survive. Challenge.
I, like the first speaker, am very new to Tower Hamlets and in fact to Britain, so I'm just trying to get a better understanding for the new multicultural area in which I work. I also work with an older adult population, so I'm really trying to get an understanding of ageism within the context of different multicultural areas.
At one point I kept coming across is the how to sort of marry up the concept of fate with health concepts of active patients and empowered patients, especially dealing often with what was earlier probably described as the very practicing but not so well-informed client group. And there's often to marry that up, because there's a sort of clash of concepts and understandings at times. So that's what I'm trying to get out of the discussion.
I'm Karen Robb. I'm consultant physio for acute cancer care at Barts. I'm working with Klaus on our rehabilitation and survivorship initiative, and it's really just thinking about how to best implement behaviour change in light of secondary prevention, healthy lifestyle, diet, physical activity, that sort of thing, and how we can marry that together.
There are 8 cases here, and so this is a bit of small group work to hopefully elicit some of these. You've heard the kind of things people are interested in. These cases will offer some insight into those. They're all fictionalised, but they do reflect a lot of reality.
Blood sugar is being not titrated with the insulin given, and also the healthcare professional should walk around looking into his HbA1c, trying to give him more appropriate, whether insulin or increasing medication regarding that poorly controlled, diabetic, and then coming into agreement with him, kind of carrying out care planning.
Is there anything we can ask to understand perhaps what some of the more underlying blockers might be? Because in terms of, it may be that the fact that he doesn't want to take his pills or his reliance on smoking and things like that. If you're right, for example, that he can't be a taxi driver anymore because he's got the stroke, presumably there's like a confidence issue, perhaps around having lost his main occupational status.
All right, this group was talking about case 7. So Mr. Akmal, 37-year-old, who's diabetic, overweight, wants to, or attends asking whether it's appropriate for him to go on Hajj.
For the healthcare professional to know the issue around Hajj as well, so as the healthcare professional will be able to put that together to impart on his poorly controlled diabetes and his overweight, and also discuss about what the requirements he needs to know about, care planning about the diabetes, because obviously it wouldn't be that he's only starting to decide that he wants to go for Hajj. It will be something that he's been planning for. So before then, the healthcare professional will know the issue around making him to be aware of his health issue, so as to be able to manage himself very well before going and also during the procedure of Hajj.
What we are doing this morning is that we had a group of healthcare professionals, doctors, nurses, from all sorts of backgrounds, trying to understand some of the issues that they face when dealing with their Bangladeshi Muslim patients. There's something that troubles me, and that is when I look at national data on health and I compare different communities, we find that Muslims have the poorest health in the UK. And so the question for you is, why is that the case?
There can be so many reasons. First of all, people are divided the Islam into some parts. Some people are just following some part of ibadah, like salah and like zakah and like tasbih, these. And there are so many parts of Islam which are not followed properly.
We are not following 100% what our Prophet sallallahu alaihi wasallam said. And one of the Jewish people during after Prophet Muhammad death was wondering to one of Sahaba and said that Prophet Muhammad told you everything, even how to use, how to enter the bathroom, and how to deal with so many things. So he was wondering about such advices to the Ummah from the Prophet Muhammad. So if we 100% following the Prophet Muhammad sallallahu alaihi wasallam advices,
how are we going to try and change the profile so the Bangladeshi community, the Muslim community here in Tower Hamlets, changes from having the worst profile to the best profile? How would we do that?
It's I do like this. We said Prophet sallallahu alaihi wasallam advised us to pray 5 times. So it's actually, it teaches us, it gives us a lesson how we need to be scheduled, or how we need to do everything in a system. So if we first of all, I say them, if we follow timetable, like eating timetable or praying timetable, waking up timetable, lots of people, those are just, they don't have any fixed time to go bed.
It was interesting that one of the doctors was saying that if you look at the community, particularly the Bangladeshi Muslim community as a whole, and if the community's condition is personified into a person, if you look at it as a person, I shouldn't say it in these words, but if you can understand it like this, that if the community was represented as a person, then that person would be would be critically ill, and would actually be in need of emergency care. You probably have to be dialing 999. So as a community, we're actually in a situation where 999 should be dialed for us.